Hi, my name is Francois Prizinski. I'm a doctor of physical therapy and fellow in training at SportsMedicine of Atlanta's Orthopedic Manual Therapy program, which is accredited by the American Physical Therapy Association. I've been invited by Dr. Bob Duval and Oakworks in part of their educational series for cervical spine. And if you haven't seen our first video, which was vertebral artery insufficiency, screening testing, and current literature, we also provided clinical pearls. Please do so. I think there's some great information to attain with that. What we have for our next segment today is looking at special tests, particularly in the upper cervical spine for cervicogenic headache. We're going to be talking about cervical flexion and rotation test, the sensitivity, well, I should say specificity, positive likelihood ratio, and what's called a quadus score when viewing any special test. So the intent for us today is to use products from Oakworks and how they're applied clinically with the clinician in mind, given the firm response foam tabletops, given cervical mobility testing and assessment through manual therapy techniques, a firm end feel is appreciated consistently each and every time. So we'll talk about that in a few minutes. In addition to the drop-away headrest, which comes in handy particularly with this treatment area. So our first test that we have for you is the cervical flexion and rotation test. And as a reminder, the quality of looking at these special tests are for specificity greater than sensitivity. Sensitivity is to rule out a condition, similar to our VBI discussion, but we have mentioned that the sensitivity for a specific test on VBI is extremely poor. In our special tests, we're looking for specificity features, which we're going to talk about. But more importantly, I think this is a good place to talk about what's called quality assessment of diagnostic accuracy studies, or better known as quadus score. This is a 14-point critical analysis looking at yes/no questions, examining the methodology of a study to deem quality of that study. And so what we look for is a score of 10 and above. This is a 14-point scale. So 10 and above is deemed good methodological findings and procedures when performing a test. So we can draw some stronger conclusions than if the methods of the test are poor. Also, when specificity is looked at, specificity, spin, specificity, when positive, rules in a condition. These are our special tests. When correlated with a positive likelihood ratio, that is to rule in a condition in favor of finding a true positive finding. What that means is a positive likelihood ratio of 5 and greater will present itself with a significant shift in the probability, meaning that we are looking at a true positive. Now, going back to our cervical flexion and rotation test to look for cervicogenic headache, the quadus score for this particular test is 12. That is extremely good. Also, the positive likelihood ratio for this test is an 18. All right, so we said anything above 5. So this is a very powerful test. If we're not using this test clinically, we should seriously consider it, particularly in the upper cervical spine for treatments of cervicogenic headache. Now, what we'll do today is demonstrate the test and also the treatment application when using Oakworks PT 250 table with the 2-section table and the firm response and slidable headrest. So can I have you come over and we can demonstrate this? Please, lay on the back for me. All right. So, what you want to look for, this is the cervical flexion and rotation test. The first piece is to move into cervical flexion. Okay? Now, I am trying to take her to that nice end point, okay? And here's where I want to make sure that I have a firm end feel, and that's where the table comes into play, where I have firmness of the table without as much give to ensure that I am at a good end feel. Or otherwise, we can have false findings if we don't have a good end feel and we begin the rotation piece, which is number 2. So number 1, cervical flexion, end feel, firm. Are you okay with that?
Yes, I am.
And second piece is rotation. So we're going to rotate her to the right, and we're going to go to that end point. I have an end feel. So I can ask the patient in this position, how does that feel for you? She might say, that's my symptom. That bothers me. So the cervical flexion and rotation test is not only a range of motion test, but also a pain provocation test. So number 1, what is the quality of that end feel and what is the reproduction of the symptom? Number 2, what's the range of motion value from this position, lining up the goniometer with the sternum and using the bridge of the nose to get a measure, and I want to compare that to the contralateral side. So I'll go to the other side. How's that? She may say, oh, that's fine, yes, okay, that's good. Take a range of motion value there, okay? So a positive test, thank you, is to look for a difference of 10 degrees or positive reproduction of the chief complaint, okay? In this case, we're looking at cervicogenic headache feature, particularly described on unilateral and may, in fact, radiate into this position. Now, here we're going to move right into some treatment. Let me have you lay on your belly. So, Oakworks table, having the adjustable headrest. We're going to take advantage of the foam cutout. And what we'll look for now is a differentiation. Some of this work is being referenced out of the Maitland physiotherapy seminars in Jeffrey Maitland's work with differentiating C1, 2, and providing the treatment intervention. So the first thing that you want to do with this C1, 2 differentiation is first palpate for the C1 arch. There's not an articular pillar, but a posterior arch. Now, what you want to look for is making sure that you're up and over the patient, and the vector of mobilization assessment will be in the direction of the eye. So I will oscillate lightly into this position and progressively increase my force and look for any symptom reproduction. And so the patient can tell me. And so if she says no, then I'm going to move to my second position. I'm going to palpate for C2. Just as a reminder, C2 is the prominence, the first prominence that you feel. It's a bifid spinous process. You're going to move one thumb width away, just in a lateral direction. Here we're looking at the left side, and provide your assessment there. So in this position, I will ask, and she'll say nothing, okay? Here's your clinical pearl, guys. Keep your thumb in this position. I'm just going to have you turn your head over for me just a little bit. Perfect. 30 degrees of ipsilateral rotation, keeping the thumb in that position, and now assess once again, okay? Often, very often, with this positive cervicogenic test, you will find this to be the positive feature. Let's pretend like it's not the case, okay? So what I'm going to do is use Oakworks table to depress and have her just relax into that position. And I'm going to appreciate a little bit more of a functional position. Oftentimes, it's the flexion rotation. If they're reading and they feel the symptom feature, I am assuming a position here that is more functional to perform and apply my mobilization to. Now, you'll get right back to your C2, just lateral, and provide your oscillation at that time from this position. Now, she may say that, oh, that's too intense. Here's the nice thing. I can just adjust it just a little bit, and it will make a significant difference in the patient's comfort level, and I'm able to really appreciate and find the position for the patient to feel comfortable, to relax, so that I can really execute a solid mobilization from this position here. Following my treatment of oscillation, let me have you go ahead and flip back over on your back. We're done, right? No, we have to reassess. So what are we going to do? We're going to go right back into our same position for the cervical flexion and rotation test. So I'm going to go into full flexion. I have the firm response tabletop. I have a nice end feel, consistent and reliable. And I'm going to rotate to the right. And I'm asking my patient, not a closed-ended question, but an open-ended question. How does this change your symptoms? And she could tell me better, worse, or the same. Okay? Also, from that position, I can take a look at obtaining a second range of motion measurement to compare it to my first to see if that is truly, in fact, a change in the special test. Go ahead and sit up for me. Thank you. So we're done, right? No, we still have one more thing. Spin those legs around. And so the last piece is allowing the patient to go home with some type of functional activity. Now, we didn't screen for the upper thoracic area, okay? But at least in this case, we would leave you at least with some additional information with some deep cervical neck flexion endurance, which is some great reference work by Gwendolyn Jull, but also for her to perform simply cervical flexion and rotation. Some remember this as 2-finger, 3-finger, however many fingers, and perform rotation to really keep the range of motion that we've acquired today. So hopefully we'll see you in our third segment, which we're going to take a look at specific and local mid to lower cervical neck pain with the assessment and treatment application using OakWorks PT 250 two-section table with the adjustable headrest.